So I'll get started. So Catherine had mentioned, and rightfully so, that current genetic testing in the modern era really focuses on symptoms and really focuses on patients who are already diagnosed and then undergo genetic testing. But we clearly see that that's not enough currently. We clearly see that these patients are being diagnosed late, like Mark Silver had mentioned, and currently what we're doing is not enough. We're identifying them too late, and these patients already have a higher mortality than their counterparts. So something needs to change. We know that these patients are already underrepresented in clinical trials, and if we can identify those who may be at risk for developing disease earlier, there are preventative methods that are being explored in vitro models currently. And so once, yes, though these are not prime time yet, but once these go into effect, we're going to see more of a shift towards preventative therapy for amyloid rather than treatment of amyloid in the future. The last thing I want to mention, and I'll pass it off to Sonia, is the cost of drug. So cost of tafamidis, as we talked about earlier, 225,000. This is a disease process that has already been underrepresented and underdiagnosed in several areas and geographic locations within the US. And that's what's contributed to the high cost of medications for these patients. If we can identify more patients at risk and subsequently more patients who may develop disease, we're expecting the cost of medications, disease modifying medications that can be life saving, to go down for a vulnerable population.
Yeah, I think those are really great points. And, Catherine and I were chatting ahead of time saying that we were probably going to have a lot of similar slides and points coming from the same professional perspective. And she was most definitely right. There are certainly complex results we can get back from genetic testing, which is why genetic counseling or involvement of a geneticist or other genetics professional is really important with implementing this type of testing. Should the lack of resources that we currently have available make us say, no, we shouldn't do this? I think it means that there's a goal for what we should be doing in the future and a future that we should be building towards. Dr. Silver, you had mentioned, from that Ambry report that you got, only 15% of Black patients had come back with a pathogenic result. In my head, that shouldn't be an only, that should be a 15% came back with a pathogenic result. That's 15% of that population who now has something, if not actionable, educationable, if that's a word, that they can be chatting with their providers about and letting their family members know about. Education, like you mentioned, is so important. Educating about symptoms we should be aware of and, things that family members should be aware of. Yes. And that's really the importance of genetic testing and the education that comes along with it. So, I think that's a big percentage in my head. I know that's relative, but in my head, that's a big percentage of people who could be benefiting from this type of testing.
Are we moving on to, yeah? Oh, how, don't know the protocol.
Yeah, I think just chat with us, that's fine.
Okay. All right, so did you want to go first?
No, go ahead.
Okay. So, I suggest that we implement, I love what you said. I say we work together. I suggest, honestly, I think what this is all coming down to is increasing education. And I think if we start there, because I would agree with you that the prevention piece is huge. And the whole purpose of screening in genetics is prevention. And that's exactly why we do what we do as genetic counselors. We do that because we want to prevent diseases. So I say we work together and not argue and decide who's right, and say that we do some education around why it's important to know about your symptoms. What are the symptoms? What is genetic testing? What isn't genetic testing? How will it help you? How will it help your family? How will it help your clinician? How will it help the researchers? And if with that piece, with that education piece, you increase the number of jobs for genetic counselors who could be doing this education and implementing some of these strategies and working with the clinicians and working with the research studies.
Thank you. I'm all into aspirational medicine. And I was talking with Paul earlier. We both worked in an area that led to the transformation in heart failure from beta blockers being a taboo drug therapy to being a mainstay and one of the four pillars. So I really get that. And the 15% I'm proud of too. The problem is that, and I looked at our personal results, it's 50-50 split between wild type, which doesn't help you, and then we also have a lot of ALs too, and that the genetic testing doesn't, and they're very confusing. There's a huge overlap in how they present and their disease dysfunction. I do have one slide. Can you just advance one slide? There you go. Actually, two. So that's good, and I can't read it from here, so I'll fake it. But this rebuttal comes to you from one of my patients. He was a gentleman who came to us. I think he's 78. I can turn around and read it. 76. And he had a very long history of systolic and diastolic heart failure. What's bolded are all the signs and symptoms that should have been aware to multiple providers for many years. Multiple ER admissions, recurrent thoracenteses for pleural effusions. He had functional class 4 symptoms, sleeping in a chair. His initial EKG had low voltage. He had bilateral carpal tunnel syndrome with repairs going back 2 decades. Echo showed thick walls and thick mitral and aortic valve leaflets. You didn't see it in that pathology slide I showed you, but pathologically, amyloid is everywhere. It gets on the aortic valve leaflets, the mitral valve leaflets. It encases the small microvascular arteries, which is one of the causes of angina. Recurrent pleural effusions. And here's the killer, so to speak, is he was a family of 6 siblings, all who had carpal tunnel and were diagnosed with fluid buildup. And his youngest sibling, oh, thank you, April, you're the best. But his youngest sibling died last year from fluid in her lungs. And then he had 5 children. And one of the daughters who came with him to the appointment turned out that she got tested and has the disease. The other 4 were unwilling to get tested. So we have some wins, but we don't. It's not a grand slam, to be sure. And so I said to him, isn't it great that we were able to at least find out about your daughter and at least give her perhaps a decade or 2 or 3 of earlier intervention, which is what I think is, I think you just said it, that we have to treat these patients much earlier. The kinds of patients that I saw pathologically, there's virtually no hope for them. There's some new drugs that are trying to get the amyloid out of the heart, which is really what we need. But you have to start very early. So I said to him, wouldn't it have been nice to have this testing for your relatives, decades ago? And he said, Dr. Silver, we were poor, we were black, and we were in the southern part of the United States. So even if they were giving it away at the local drugstore, we would not have had access to it. And I think that underscores the tremendous disparities that still exist, that are barriers to getting things to the right patients at the right time. We should not stop from doing what you're suggesting, but I think we have to put those resources for now into those approaches.
Well, certainly, thank you for the fantastic discussion and certainly bringing out some of the pertinent questions and issues that relate to this topic of testing. So certainly hearing it from the genetics, the pure science standpoint, as well as from the cardiology, which is going into more healthcare and patient management standpoint, getting these ideas out into the public, out into our realm, so that we can try to decide what's best has been good. You've elucidated several things concerning insurability, the science of the test, certainly the affordability is very important, perhaps the impact on healthcare systems and being able to access care once you need it, and then certainly the desire and patient interaction. And I think that that could segue to the next little portion that we have here, which is actually a patient who has, or a person who has ATTR, cardiac amyloidosis. And certainly he's had an opportunity to experience issues with screening and understanding testing, and it would be nice to get his perspective as well. So I'd like to introduce to you a friend of mine, Tab Blackshear, who can tell you his story and certainly be open for any questions too. Thank you.
Good afternoon. My journey with hATTR amyloidosis started long ago. I was thriving in my career and had been active in many sports. But one day in 2009, I noticed shortness of breath while I was exercising. I immediately thought it was a problem with my lungs. After a series of lung screenings, the doctors came up with nothing. Through my Googling, I began researching why I might be experiencing shortness of breath. I needed to take charge of my health. Once I started sifting through the information, I remember a sense of relief came over me. That research led me to a cardiologist. Multiple tests were done, and although this doctor had no answers, he did have a recommendation for another cardiologist, which led to a heart biopsy to determine what was wrong. This entire process took over a span of about 3 years. The results were returned with a diagnosis of hereditary ATTR amyloidosis. The doctor took the time to explain that the transthyretin protein being produced in my liver was being deposited in my heart as amyloid. This was causing my heart to harden, which led to a heart transplant. I also experiencing carpal tunnel syndrome and neuropathy. I now want people to realize that they have to first find out what their symptoms mean and to know what hATTR amyloidosis is so that they can get screened for it. The symptoms are such that the warning signs are hard to identify. It's easy to chalk it up as shortness of breath or age or stress. To give the gift of an early warning sign through screening, something they might not have otherwise, would provide them with more information to make an informed decision as to how to develop a path forward to manage this condition. Thank you.
We have certainly had a lot of inspirational speakers tonight. I think the audience can agree with me on that. So there are lots of food for thought for us all, lots of important points that have been raised, both from a molecular genetic standpoint, from a clinical cardiology standpoint, and from a patient perspective. I think we can all see the benefits of this being a potential way for the future, but also agree that it's not prime time yet. So I think one of the things we can draw from a lot of the message today is that it is what we are hoping for to happen in the future to improve the overall care, to drop the cost of the medication by picking up many patients who may benefit from it, allowing many to be able to enroll in clinical trials, and actually preventative medicine, which is the best, to allow many people to proactively prevent the symptoms and get the care that they need. I want to put it out for the audience to also, if they have questions, we have a lot of intelligent and inspirational speakers here, and they will be perhaps happy to also address questions if the audience have questions.
I know there was a lot of talk about the. Sorry, we're going to give you the mic. Thank you. I know there was discussion about the, for an argument against having testing offers all Black Americans for the cost associated with genetic testing and then with the treatment itself. But I was wondering if there's any data on concerns. Oh,
But I was wondering if there was any comparison of the cost of that compared to the cost of, if there isn't screening, the delayed diagnosis time, and like even in Mr. Blackshear's experience, 3 years of referrals and biopsy to get to that point, to just compare how the cost differs with or without screening.
We'll throw that open to the speakers, whoever is willing to start the discussion.
I can start. So, excellent point. So, excellent point. I don't think there's, and Mark can kind of fill me in as well, but I don't think there is data out there comparing the cost from time of symptom onset to diagnosis to then therapy compared to costs for implementing a genetic screening strategy upfront, because we don't have that genetic screening strategy upfront currently. So that will be something that we are hopeful to look for in the future, and to see if we actually do see savings down the line from a healthcare perspective.
Yeah, no, I agree. I don't have any information either. But I mean, if you look at public health approaches to health problems, the greatest impact is when there is a public awareness campaign. Smoking cessation, wearing seatbelts, cancer screening, breast cancer screening. It all comes with awareness, and that leads to then the institution of dedicated resources to diagnose and treat those patients. So, we have to do it all. Unfortunately, we have restricted resources, and so I think it would start, even with Tab's comments, as when he told me the delay in getting to a final diagnosis, I had a conversation early with Dr. Mayer about how long it's taking even in his patients to get from initial impression to a diagnosis. It's just too long. And so I don't know if that's answering the question, but I think we need to learn more about that.
There's another question. Could you ask?
Well, I think, hi, Eric Studley. Thanks for this great sort of collection of wisdom, and of course, like most good conversations, more questions end up at the end than we started with, right? We started with the question of should we screen all Black adults for TTR? Now it's going into health disparity questions and allocation of resource questions and all of this. But just a couple perspectives for screening purposes. I don't think in the field of heart failure we really made any traction in education, despite the valiant efforts of many folks, until a lot of these beta blocker ACE inhibitors ended up popping up on our Epic screens, forcing us to prescribe that. And if we didn't, we'd get a report card back from our chairman at the end of the month why these people you discharged were not on ACE inhibitors. So I agree we could spend a lot of time educating, getting awareness about carpal tunnel, about spinal stenosis, et cetera, LVH, on all of the stuff we already know about in this room. But until it's forced into an algorithm that pushes it to the clinicians where they have to click, we talk about AI, I'm looking for some NI, I don't know, natural intelligence, I'm not so sure, just a reflex. And so I guess I'm even sort of contemplating, I wonder if because this really is a math problem, right? It's what percentage are we, where do our values lie, and at what cost do we want to detect disease? It's a values question, right? Do we want to detect it at, we want to make it $50,000 per year life gain, $200,000? I mean, it's a values question. So I'm wondering, if we modeled that for just a healthcare system and say for every African American patient that touches the healthcare system, so now not all people, but whether you come to the hospital for anything, outpatient carpal tunnel surgery, inpatient heart failure exacerbation, quote unquote asthma, right? If you touch the healthcare system and you're over the age of 18 and you're a self-identified Black, maybe that model works at a math where we can get down to maybe not 3%, maybe that's 5%, maybe that's 10%. So I just think probably we're going to start at our own institutions, but and come up with our own ways to sort of build it, force it into our system. But maybe I'm talking too much, but I don't necessarily have a question. But I'm excited to go back to work and sit down with Sonia and draw some of these things out on paper.
Right.
Thank you for the very important reflections and comments.
Hi, good evening. I'm Indrajit. I'm one of our residents, so I'm very early in my career. My question is, if we start screening everyone, and with the cost of the drug not coming down, would it not lead to just lead time bias?
Could you explain that a little bit more?
So that yes, we will detect a bit more, but if we are not able to provide them adequate treatment because that price of a drug is too high, so is that actually going to help us reduce the mortality, or is it just going to help us just know that, well, yes, we detected it early, but what are we doing with it?
Yeah, well, first of all, I totally agree with you, and I totally agree with you, and I don't think we're just detecting it early. I mean, right now, the people who come into the healthcare system are ill. I mean, we see very few people who really come and show up for preventative care with these signs and symptoms. So, I don't think that doesn't mean that we shouldn't do it. It's one of those things, if you think of it, you should do it. And it's very rewarding when you find it. But yeah, I don't think we're having the biggest impact yet, but we will.
Thank you so much. Also, I would have a point I want to make sure our clinicians are be aware of it. It goes back to a very interesting question one of my resident has when I was a junior faculty back in Texas. We used to have 2 weeks at a time rotation inpatient. We had a CICU and interventional cardiologists. I was heart failure, general cardiologist, even EP, they would take turn. And one of my residents said, how come, Dr. Mayer, each time you're in rotation, we have 2 amyloidosis by end of these 2 weeks? And I said, because the mind was prepared. So we see these patients every day as a cardiologist because we're not thinking about it. This is the same guy that keeps coming back, but I happen to get more curious, check some tests, and it comes back amyloid, and we go from there. I'm not seeing more. I'm just seeing the same patient, but my mind is more prepared. So I think one of the things is about we should be aware of it is that yes, we can do genetic testing and everything, but if your eyes are closed, we have so many lab tests we do every day. We don't, how come somebody noticed that someone is hyperkalemic, although this potassium was always high? Because nobody looked into it. So you just kind of screen over it and you don't just kind of overlook it. I think that's something that we should be aware and work on our clinicians to be more aware of it, is that there are certain disease that comes in with a certain manifestation. We should think about amyloidosis, and that itself helps us a lot. Everybody knows about the test PYP scan, for example. It's been overused in my opinion sometimes, but we see the same problem, but we look at it a little bit differently. Then we overlook diagnosis. I think that was something that I think we need to work on it in our community, about more awareness of the clinicians of this disease.
I agree with you. Ali, I agree with you completely. I agree with you completely, and I want to call out and thank 2 forces that have been instrumental in really changing the trajectory that we have. One is Matt Maurer. Matt is one of, everybody's shaking their head. Everybody knows Matt. Matt is a friend of mine, and really took an interest in this and really raised the awareness through a series of studies and formulating the Taos registry, and was inspirational for Pfizer for the development of their drug. And the rest is all the other pharmaceutical companies there's so many new drugs on the horizon that are novel, that are overlapping, that can be used to help patients. And they really have the terrible task of trying to go back to clinicians who ought to know about the signs and symptoms of heart failure, of amyloid, and are really sort of obscure about it. So they're really driving awareness, and I appreciate those efforts too.
And just to add on to what, Mark was saying, with new drugs on the horizon, remember, tafamidis was designated as an orphan drug and really one of its kind. And so that you can't say completely contributed to its cost and the disparity associated with that, but definitely is part of the reason that we're dealing with such high costs with this medication. So with new drugs on the horizon to treat this condition, to have more identified patients with this condition should help with costs for future medications as well.
Agree.
I think one thing that we've been hearing is that is the way of the future. There is a lot of hope, especially with the testing volumes that are going up. Patients are having direct to consumer test access, and they're coming to the clinic. So there's preventative medicine going. Increasing awareness also in clinical medicine will lead to increased diagnosis. And this may overall help us understand the reasons for incomplete penetrance, variable expressivity, and also increased patient enrollment in clinical trials. Well, I think it is hoped that this will translate into improved understanding and treatment of amyloidosis. Is there any other question?
Thank you. Thank you.
We should thank our speakers for a wonderful discussion.
Yeah, thank you so much. All right, well, I'd love for everyone to stay and linger over empanadas and bottled water. And I want to thank our speakers again and our moderators and our patient. Really great to have you all here, and please come to our February 3rd CME event, Gila River Resort Updates in Amyloidosis 2024. Thank you.